you, Ms. Mona. So welcome, friends. Good evening, everybody. Welcome to this IndSPN virtual classroom for residents and trainees. So this is an IndSPN endeavor towards training our residents and trainees in neurosurgical and neurological aspects of pediatrics. And as you would have noted, this is a regular program every month, the last Sunday of every month. And so we plan to continue it for over 24 to 30 months, continuing to have most of the topics which are necessary for the residents, and trying to complete over those 2 to 3 years. Thanks a lot again. So, today we have the topic. Today we have, by the way, today we have Dr. Amresh Manganangre from Bangalore Medical College, who's a faculty associate professor at Bangalore Medical College, and his residents whom we have invited for this session. So we regularly invite one in unit of a neurosurgical department to do our rapport with the different departments and improve our pediatric neurosurgical reach amongst residents. The topic for today is neurological examination in young children, neonates, infants, and older children. And the faculty are Dr. Sneha from Dr. Sneha, you'll get introduced to, and Dr. Vaishak from the Institute of Medical Sciences at Cochin. You will be very well aware that the key to good decision is to have a good clinical examination, and a good clinical examination is the forefront for a good outcome and a good result for any surgical decision. So, and neurological examination in children is very challenging and probably requires an innovative approach to elicit the appropriate signs and symptoms. So beyond this, we will have our speakers to dwell on this topic. Thanks. Dr. Naveen, would you like to introduce Dr. Sneha?
Yeah. Good evening, dear friends. I think as Dr. Swaz told, that neurological examination is one of the foremost things which we should be well aware of in the neurological exam for our pediatric neurosurgery. So it gives me a lot of pleasure to introduce our first speaker, Dr. Sneha. She has done her MBBS from JJ Medical College, Bapu Institute from Davanagari, Karnataka, and has done her MD from AIMS, Mandya, Karnataka. And then she has done her fellowship in neonatology at Rangadore Medical Memorial Hospital in Bangalore. So she's been working as a consultant at the Little Stars Children's Hospital. And post-MD, she has worked in RML Hospital, Delhi, and Chacha Nehru Bal Chikitsalaya, where she got trained in her pediatric cardiology, NICU, and PICU. So I think she has also got advanced training in NRP and POCUS. And she is a specialist, has a special interest in preterm care, rare diseases, focus-guided procedures, nutrition, and high-risk follow-up. So over to you, Sneha. So,
thank you, sir. Thank you for the lovely introduction. Good evening, everyone. So I would like to begin the talk by serving the purpose of why a neurological examination of a neonate is so important. Like sir said, pediatrics is quite challenging, and neonates, it is even more challenging. So with this note, I would like to begin. Am I audible, sir?
Yeah.
Yes.
Yeah. So with this note, I would like to begin. Where do neonatologists and neurosurgeons cross paths? Right? So where do we give a reference for a neurosurgeon? Usually this happens in where we have a post-hemorrhage ventricular dilatation, that is intraventricular hemorrhage. And with hydrocephalus, we want to...
Dr. Sneha, just hold on.
Yes.
Ms. Mona, can you mute all others for the time being, because there's a lot of interruption coming? Yeah, thanks. Go
Yes.
ahead. I'm sorry, I had to interrupt you.
Okay, sir. So in case of treatment for extreme cases of hydrocephalus, where we have to go ahead with stent placements and very rarely drift therapies. And in case of diagnosed ventriculitis, that is the ventricular inflammation of the newborn, we have to give intraventricular antibiotics. And also sometimes when there is a neural tube defects like encephalocele, meningomyelocele, spina bifida, and also rarely the birth injuries like extreme cases of Erb's palsy, brachial plexus palsies involving the cervical cord avulsions as well. So next is, what is the importance of a thorough CNS examination? So I would like to give you a picture of how much the predictive ability of a CNS evaluation is there for a prognostic evaluation, guessing of how far the CNS evaluation go for a cerebral palsy. So if you can see in this slide, if you observe a tone abnormality of a trunk, upper limb and lower limb, you can predict the occurrence of CP by 12 to 15 folds. Whereas if you observe there's a diminished cry for one day itself, there's a 21-fold rise in predictability. And if you have a weak or absent suck for even 1 day, then you can guess that there is a 14-fold predictability of CP in this child. Again, so diminished activity for more than 1 day, it's about 19-fold increased chances of having a cerebral palsy. So this gives you a clear picture about what is the importance of a thorough CNS examination of a newborn. Yeah. So coming to the examination, that is a newborn by a neonate by definition is 0 to 28 days, but it varies in case of preterms. Like nowadays, the preterm age is like viable preterms are until 24 weeks. So it from this 24 weeks to 40 weeks, the baby can range in those gestational ages. So always, like any case, we have to have a thorough history, and gestational assessment is very important because a preterm will definitely vary from the term babies. Term baby as in who is born full term, that is 9 months of pregnancy. Preterm baby is before 37 weeks of gestation. So next is the general physical examination. So as we all know that mainly neurologically, if we have to concentrate, we have to go look at the head size, the occipitofrontal circumference, microcephaly and microcephaly. And in the face, you can observe for any obvious facial asymmetry. And in the spine, you have to palpate and see if there's any swelling, hemivertebras, and if you can see any tuft of hair or dimples. So next comes the normal behavior of the child, of the neonate. So there are quite different classifications of the behavior in a baby, in a neonate. There is one such thing called Walpe's classification, in which you have to examine the baby might be in alert stage or in deep sleep, or he might be irritable and crying. So the best time to examine the neonate will be when he is just after a feed or after a sleep, when he's quite alert state. So in this state, you can see that the baby has spontaneous movements. He is not having any jerky or asymmetric movements, and he is able to comfort himself. That is, you can see any normal newborn, he'll be able to comfort himself by sucking on his fists, which is a very favorable behavioral response. Apart from that, he should have a definite response to light and sound, and also habituation. So by definition, habituation starts in utero, as early as 26 weeks in utero. So the baby can get habituated to stimulus like sound, touch, and ex utero to light as well. So these are all the normal behaviors which you can observe in the newborn. So I'd like to mention specifically about the cry, because the nature of the cry in a newborn tells a lot about the neurological status. For example, a shrill cry may give you a clue about meningitis. Rarely a hoarse cry can give you a clue about the cry-do-chat syndromes, and a weak cry can be a sign of depressed sensorium or a vocal cord palsy as well. So coming to the cranial nerves, so cranial nerves, you don't have to do special maneuvers for the baby in a neonate. You have to always observe the spontaneous activity. If you see the baby is crying, look for any facial asymmetry. So that will give you a good idea about a cranial nerve 7. When the baby is crying as well, if the quality of the cry is good, so the cranial nerve 9 and 10 are intact. And sucking and swallowing, these are very coordinated and complex reflexes. So these two things, if they are good in a baby, then you are rest assured that cranial nerve 5, 7, 9, 10, and 12 are good. And eye movements, these give you an idea in a neonate about cranial nerve 3, 4, and 6. So doll's eye maneuver can be done in a newborn, and it is expected until 12 weeks of age to be normal. Whereas in adult, we don't expect doll's eye maneuver to be normally there. And when you check for the behavior of the baby to light, when blinking is there or the baby is turning away, you can analyze that the baby's cranial nerve 2 is intact. And when the baby responds to sound by either startling or moving towards the sound, turning towards the sound, it gives you an idea about the cranial nerve 8. Apart from this, other reflexes like gag reflex, corneal reflex, and pupillary light reflexes, also fundoscopic examination, are the same as we have done in the adult examination as well. So I'll be demonstrating a few cranial nerve examinations in the video later. So this is about the cranial nerve examination. Next is tone. We give a lot of importance to the tone in newborn and also in the high-risk follow-up of the babies. So why? Because it gives a gross picture about how the evolution of the tone is, and whether the baby is probably going to be a cerebral palsy child. So tone is grossly divided into passive and active tone, as we all know. So in that also, we want to see for the axial skeleton tone and the appendicular skeleton tone. So how do you look for an axial skeleton? In that, for a passive tone, here we can see that if there is any resistance to the baby's, when we are turning the baby's neck to the opposite side, the lateral part, if we feel any resistance, then if there is any hypertonia, we'll feel a lot of resistance. Again, when you ventrally suspend the baby in this next picture, when you see here, the figure A shows that the baby has a good tone. He's not completely hypotonic as demonstrated in the picture B. If you can all see this. So baby is totally hypotonic in this, whereas in A, he's maintaining a good tone. Next is when we are checking for the axial tone, we have to look for the active tone of the neck and neck extensors and the flexors. Here, when we bend the baby a bit while supporting his shoulders and the head falls down, he tries to lift up his head at least a few seconds. The same thing goes when we are checking for the neck flexors. So when we lift him, pull to sit from the table, he tries to bend his head forward at least for a few seconds. That is the tone or active tone of the baby in the axial skeleton. That is the neck. So this picture, you can see that there is a gross hypertonia. Sometimes the mothers will be very proud and coming and saying, my baby is just 1 month old and he is already holding his head. He already has a neck control. So we have to be very alert. That's a red signal because that actually signifies a hypertonia of the neck muscles. Whereas here you can see there's a gross hypotonia. There's a head lag when you're trying to lift the baby. The head is lagging behind. Next is appendicular tone. So here we have appendicular skeleton. Here there are a few maneuvers which are just very particular in the newborn age. So we can check for the passive tone with these maneuvers. This is called as the scarf sign. I will be demonstrating in the video as well. So here we have to try and pull the baby's arm towards the opposite shoulder. If we see here that the elbow is crossing the midline or the limb, that is the hand is going to crossing across the opposite shoulder, then there is some hypotonia. So actually this is again having different angles for different gestational age, but grossly we have to remember the feel when we pull the baby's hand. If it is very hypotonic and almost crossing the midline, the elbow is crossing, then it's a hypotonic baby. Same thing goes with the square window. This is to check for the tone in the distal part. That is, if we have to flex the baby's wrist at this point, the angle which is formed here, this is called as a square window. So when it is very acute, then the baby has hypotonia. So this is for the lower limb passive tone. This is one of the important examination of a newborn. This is called the adductor angle. So after holding the limbs, stabilizing them at the knees, we have to try and abduct the lower limbs. So the angle formed between over here, this is called as the adductor angle. We have different values for gestational age and also throughout the infancy. We have to compare with those values and look for if there is any hypertonia in this baby. Same goes with popliteal angle. So after holding the baby's lower limbs up to the abdomen and try to stretch the legs, the angle which is formed here between the leg and the thigh, marked with the black arrow here, this is called as the popliteal angle. So if it is markedly extending directly almost obtuse or even 180 degree, then there is a marked hypotonia. If it is not extending, then it is hypertonia. So here I have given two pictures of heel to ear maneuver. This is when we try and extend the baby's heel towards the ear. Here you can see that the Down syndrome baby, for an example, here he has extreme hypotonia and his heels are almost touching his ears. Whereas here in the other picture, you can see that there's a normal tone in a term baby, whereas his toes are not touching his ears. So this is about the passive tone in the appendicular skeleton. When we come to the active tone in the appendicular skeleton, we have to try and do a vertical suspension of the baby. That is, support him under his chest and try to lift him. When we see that, the upper limbs should normally be placed on the side of his body. That is, his resisting to slip away. Whereas here, if you see this picture, here he's almost slipping away. So that giving the sensation of slipping away is a demonstration of hypotonia, extreme hypotonia. So the next thing is Parma grasp and plantar grasp. This gives you an active tone assessment of a appendicular skeleton as well. So here, Parma grasp, we have to just stroke on the inner aspect of the hand, and we'll observe that the baby is trying to grasp our fingers. It is so strong that the baby here, you can see that he's able to lift himself with that, just that support. So it gives you a good idea about the tone in the peripheral muscles. Same with the plantar grasp. When we just stroke at the ball of the lower limb, that is the feet, the fingers will flex. So this is a plantar grasp. So this gives, until here I've explained more about the tone of the baby. So next is a set of primitive reflexes, which we should not miss in a neurological examination. Keep in mind, there are almost more than 73 primitive reflexes. So the demonstration of each and every reflex will take time, and as well, the baby might not cooperate. So just keeping the few reflexes which are very important and we should never miss. So these are Parma grasp, rooting and sucking reflexes, asymmetric tonic reflex, Morose reflex, truncal incurvation, placing reflex, and stepping reflex. Why I want to concentrate on these reflexes are, these are some of the primitive reflexes which have to begin at a certain gestational age and mature at a certain point of time. Like for example, a Morose will mature by term, and it should be completely formed by term age, and it should go away by 4 months. And the same with asymmetric tonic reflexes. If there is a persistence of these reflexes into the infancy, more than what the designated expected time is, then there is a predictive ability to guess that the baby has some neurological abnormalities. So more than the pictures, I think the videos will tell a more, like demonstration of a video will give you more idea about the reflexes and the evaluation. So this is, he's our preterm baby. He was delivered at 32 weeks. I have tried to put up a compilation of all the neurological evaluation as much as possible. The ones which I could not demonstrate in this video, I have tried to borrow a few videos from University of Utah. So yeah, I'll just play this video. I have an audible explanation along with that.
I'm showing you a demonstration of important neurological evaluation. So he's in a quite, the behavior if you observe, he's quite alert and he's responding to stimulus like my voice, also the light stimuli. He has spontaneous movements which are non-jerky and smooth slowly. And right now, once he's crying, if you can observe the nature of his cry, it's neither shrill nor dull. So it gives you a good information about the cranial nerves as well, because there's no asymmetry as such in the face. So this gives you good information on the cranial nerve 7. And if there's any hoarseness of voice, then we can also rule out the, when there's no hoarseness of voice, we can rule out the cranial nerve 9 and 10 as well. Once if the baby is sucking and swallowing well, that gives a good idea about the cranial nerve 9 and 10 and 11. So coming to the cranial nerve, coming to the rooting reflexes, if you can demonstrate. Yeah, so I think the peaks. Maybe more show extension of tongue and turning towards the stimulus. Yeah. Coming to nervous reflex. You can observe there is extension, adduction, and then followed by crying. So this will give you a good picture of the reflexes. Coming to the lower limb reflexes. To stimulate one of the limbs, cross extensor reflex. First, this. Coming to the stepping and placing and stepping reflex. Once you scroll from the interior aspect of the jaw, baby should place the lips above. Probably will take it another time. Coming to the tone assessment, it's divided into axial tone and appendicular tone. So in that, for passive tone, just observe the feel when you turn the baby's neck to the opposite side. If there's hypotonia, there will be no resistance at all. Here the baby is demonstrating good amount of resistance. Next is axial tone by ventricular suspension. Then, baby holding the chest and abdomen. So you can feel that there is a bit of tone and there's no gross hypotonia, otherwise the baby would be completely flexed. Coming to the peripheral tone, that is the appendicular tone, demonstrating the scarf sign. Right? Hold the baby's upper limb and stretch it over the opposite shoulder. If it is crossing the opposite shoulder, then there is gross hypotonia. Right? Demonstrating the square window. So if there is marked hypotonia, the angle will be very less. In this, it's about right angle, which is correct for the baby's gestational age. Next is the arm required. Just gently pull the baby's arms. So you can observe the spontaneous recoil of the arms. So coming to the lower limbs, we have to check for the vertical angle. I'll be showing you a demonstration of component. I'll be showing the lower limb tone. We have to assess for the adductor tone. Try to separate the hips and holding on the like this. And if there's marked hypertonia, the angle will be very less. And if there's marked hypotonia, then the angle will be very large. Next, coming to the popliteal angle. So you have to hold the baby's lower limbs up to the abdomen and try to pull the leg. So this angle which you see here is the popliteal angle. In a completely hypotonic baby, the angle will be almost obtuse. But in a completely hypertonic baby, the angle will be very less. Next, in the same baby, we can see for heel to ear. So here we can see that the baby is not touching his ear. So he's got quite some tone, but he's not hypertonic because you can't feel the high resistance. So this is about the tone. The lower limb. The lower limb.
So that is about few of the things which I have left out in that video. I'm trying to show in the rest of these videos. So here I'm he's demonstrating the active tone of the axial muscles of the neck.
Neck muscles by putting a little bit back, and then see how he can pull his head. He does a good job there. Let's see. And then he brings his head up from being flexed on his chest. So head control is pretty good there.
So here we saw that the baby is trying to put his chin up at least for a few seconds. That is testing the neck extensors.
Posterior neck. Posterior neck.
So this video shows the same thing in the neck flexors.
Well, it should be able to get his head up here. And he does. Okay, very good. All right. A little wobbly, but he's able to keep his head up for a few seconds before he tires out.
So when we pull to sit the baby, when we extend him from the table, when we pull him, he's trying to hold the neck at least from extension to flexion position. So this is a demonstration of palmar grasp and plantar grasp.
There's a good grasp reflex there. Okay, you can simulate the grasp reflex and then lift the baby. We can get him quiet there. You can see he's almost pulling us up as far as the grasp reflex and able to hold on that hand. As far as just putting pressure here at the ball of the foot and the toe should come down in a flexion, which he does. And should grasp, let's look over here. You can see that there's a grasp reflex. Good grasp reflex there.
So this is another important reflex, that is the asymmetric tonic reflex. It is also called as the fencing reflex. It's important in developmental meaning because once this reflex disappears, the baby can roll over. Otherwise, the persistence of this reflex will not help the baby in rolling over, allow the baby to roll over.
Tested by carefully turning the infant's head to one side, which typically results in a tonic extension of the extremities on the facial side and a bending in the contralateral extremities. This reflex is also known.
So it's also known as a fencing reflex, like I said.
Tested by.
This is one of the primitive reflexes. Again, this is the Gallant's reflex or truncal incurvation reflex. That is, when we stroke on one side of the spine, the baby's trunk incurvates towards that side of the stimulus. Yeah. So these are few of the reflexes, and I could demonstrate a few assessment of tone as well in this baby. Otherwise, he was not very cooperative, so I could not demonstrate most of the reflexes in this. So I have tried to put up the videos from other resources. So that is about the newborn neurological evaluation. Other systems I have deliberately left out because the checking of the deep tendon reflexes is not routinely done until and unless we are suspecting some muscular or neuropathy. And apart from that, the sensory system, we get a gross idea during these reflexes itself, which are, we can get a gross idea about this while we are checking for these reflexes. And superficial reflexes, we usually look for anal wink reflex, which is mostly, just to rule out a Hirschsprung's disease. And other superficial reflexes are checked as followed in a pediatric exam as well. So once we have done identified a neurologically unwell baby and we want to follow him up in an infancy, so we have, I'm just briefly touching on it because sir is going to speak on it next. So I would like just to tell about a few points. We have to have a thorough knowledge about the developmental milestones in the infancy. That is mainly the domains of gross motor, fine motor, social skills, and language. For that sake, there is a special scale developmental assessment of in Indian infants, that is DASI scale. So this assesses the motor and behavior. This is a derivation from the Bailey 2 scale. And the next are very important assessment of tone in the infancy, like I mentioned. This is the Amyl-Tyson angles, that is the assessment. So this is a sequence of, usually general sequence of a baby who gross motor sequence. Usually he starts with a fetal posture. The timeline is not very accurate because I would say it's a wide range, and defining to 1 month, 2 months is not correct. But for a gross idea, we have to, we can see that the baby is lifting his chin up by 1 month, chest up by 2 months, reaching and missing the objects in the midline by 3 months. He should be sitting with support by around 4 to 5 months. And then sitting alone by 7 to 8 months here, and majorly stand with support, and then walk with support and stand alone. These are the major gross motor skills we are looking for. So the last thing I would like to touch upon is Amyl-Tyson angles. I've already briefly demonstrated all these angles: adductor angle, popliteal angle, dorsiflexion angle. I have not told about it. So it is basically when we are trying to demonstrate same as calf sign. This is the angle formed between the foot and the leg when we flex the baby's foot towards the leg. So this, according to age, there are different normal ranges. We have to compare the angles and then look for any hypertonia or hypotonia. So to round it up, so a thorough CNS evaluation in neonate can predict a cerebral palsy early and can help in better intervention and prognosis. So our eyes can only see what our brain knows. So I am hoping that I have at least shed a light on at least few aspects of a newborn evaluation. Thank you. Thank you, sir.
Yeah. Thank you, Dr. Sneha. That was extensive, and I suppose it might be overwhelming for many of the neurosurgical and neurological residents because they're not used to neonates every other day. But thanks a lot. Thanks a lot once again.
Thank you, sir.
Yeah, I think one of the key lessons is you need to be you need to be gentle. You need to be very patient, and you might have to conduct these examinations in multiple different sessions to get a complete overview of that particular
Definitely,
baby.
sir. Definitely, yeah.
You cannot make the baby cry for the sake of the exam. That is that has to be very borne by anyone who is doing it. All this. Thanks a lot, Dr. Sneha.
Thank you, sir.
Next is the for the examination for the older child. This will be done by my colleague from Amrita. He's my colleague at the Pediatric Neurology department. He's an alumni of Calicut Medical College, and his DM is from AIMS, and he's an associate professor with us. Dr. Vaishak Anand will continue on the neurological examination of an older child, a comprehensive but a focused approach. Vaishak, thank you.
Thank you, sir. Dr. Sneha, can you stop screen sharing so that I'll share my screen?
Cursory instructions to residents, they are free to ask doubts, and these talks are meant for residents, so they should try to participate as much as possible.
So at the outset, I would like to thank the organizers of this lecture and office bearers of the Indian Society of Pediatric Neurosurgery, especially my colleague, Dr. Suhas, for providing this opportunity. So my topic for discussion today will be neurological examination of young children. I'll be just dealing with what I usually do in my office practice as an approach, rather than going to the detailed examination and each and every system. So as a pediatric neurologist, the age group of children that I find the most difficult to examine are children who are between 6 months and between 5 years. Because in less than 6 months, it is easy because they are not developed stranger anxiety. You can examine them properly. More than 5 years, they are mostly cooperative and they will follow your commands. Otherwise, unless they have cognitively or behavioral issues are there. Those who are between 1 year, 6 months to 1 year, and between 5 years, those we call as toddlers and preschoolers, they are the most difficult people to examine. But in any way, we like to examine them and come to a conclusion. So this is the overview of neurological examination in any kid, not particularly in one group. So we'll start with vitals, physical examination, the whole CNS examination, and other systems. But in young children who are less than 5 years, you need not follow this sequence. You need to follow you need to examine the proper and important parts, but you need to follow the sequence that you should be first examining the cranial nerves, then the motor examination, then the sensory. No, you will have to examine the most important parts only. So from the history itself, you will have to have an idea of what are you going to look in this kid, because the window that you will get will be very short in these children. And in that window, you will have to complete your proper examination and come to a conclusion where is the result. So I will start with vitals. So it's not that important in office practice, but it's important in a case of child in ER or PICU, starting with heart rate, respiratory rate, and BP. One should be knowing the normal range, upper limit and lower limit of these values. You need not mug up the values. You can have handy the mobile apps for reference. Respiratory rate and pattern is one thing that I presume that's the most underlooked sign in children in pediatric practice, because patterns can give you an idea of what is going on with this child, whether this child is going to have a brainstem herniation or impending herniation. So this is the pictorial representation of various types of respiration that can happen in different etiologies. This is the first one is called the chain stokes breathing, where when there is bilateral cortical damage, when there is thalamic or hypothalamic damage, it happens. When there is a midbrain damage, this can lead to a pattern which is known as central neurogenic hyperventilation. And in pontine lesions, it can be apneustic breathing. In medulla, it could be ataxic breathing and bradypnea. So everyone must be knowing about the Cushing's triad, but in children with raised ICP, Cushing's triad can even have tachycardia also. So don't think that only bradycardia is associated with raised ICP in children. In general examination, starting with head circumference, I should not overemphasize the importance of head circumference to a neurosurgery crowd, but it's better that you measure the head circumference, the last part of the examination, because children will be very apprehensive when you are going to take the head circumference. Anterior frontal should be checked. Dilated veins over face and scalp for any signs of hydrocephalus, sunset sign. Retrocolis is an important sign in infants for meningeal sign, because the typical Kernig's and Brudzinski sign may not be elicitable in infants less than 1 year, and retrocolis may be the only sign of a meningeal irritation. Draining sinuses, dermoid in cases of recurrent meningitis, signs of malnutrition, neurocutaneous markers like this. The first one is the multiple cephalomacutes that is finding that you find in neurofibromatosis 1. This is a particular pattern known as pigmentary mosaicism you find in incontinentia pigmenti. These are the typical ash-leaf macules you find in tuberous sclerosis. Higher mental examination, if you are able to interact and make a rapport with the child, you can fairly assess most of the aspects of a higher mental examination. You will not be able to test each and everything like calculation, memory as you do in an elder child. In a child in ICU or in ER, you can check the consciousness. There are two parts of consciousness, arousability and awareness. You need to check that. Development milestones, if you're not a practicing pediatrician, you may not be remembering each and every milestone of a kid, but a gross idea you should be having to see whether any gross motor delay or language or speech delay is there. Cranial nerves, most of the cranial nerve examination actually you can complete just by observation in these children, because the proper examination by palpating the child may not be possible in youngsters. So in first, the olfactory nerve may not, it's not that important unless you're suspecting a frontal lesion. Second nerve, you can check field of vision by giving a toy. While the child is looking at a toy, you can introduce some other toy from the peripheral side to see the field of vision. For checking the acuity, you can use something known as optokinetic drum. There are free apps available in Play Store where you can use this optokinetic drum to check the visual acuity of children, especially infants. It's like a crude method. Fundus is important, but you need to do it last. Third, fourth, and sixth for abnormal. Is there any abnormal eye movements? Eye movements are whether they are equal in all directions. That you can check by giving a toy from all directions whether they are following it properly. Pupillary reflex is very important. I need not overemphasize that. Fifth nerve, you can just observe. Proper examination of the muscle of power of the muscles of mastication may not be possible. Seventh nerve, you can it's easily visible by checking the if there is any facial asymmetry, Bell's phenomenon, etc. While the child is engaged in a play or looking at a toy, you can just make a soft sound from one ear to check whether the eighth nerve is intact. If a cooperatory child, you can ask them to say ah, or you can just observe while crying to check if 9th and 10th are intact. 11th and 12th also, similarly, you can ask them to show shrugging the shoulder or turning the head to one side or tongue movements if they are cooperative. Or if the child is crying, you can utilize that opportunity to see whether the cranial nerves are working well. So these are the different types of pupil that one need to remember. The most important one will be a third nerve lesion which lead to a unilateral dilated fixed pupil. Motor system is the most important part, and subtle asymmetries, hemiparesis, etc. you can observe from the posture itself if there is any asymmetry, any reduced movement on one side. But tone, power, and DTRs, anyway, you will have to touch the child. So it's better that you push that examination part towards last. Gait examination is very important. If the child is ambulatory, definitely in the last part you can make the child walk to see any abnormal gait is there. Abnormal movements is visible most of the time grossly, and you will have to search for that. This was the video of a child who was a 5-year-old kid who presented with abnormal movement. This movement is called as bobblehead doll syndrome. And when the MRI was done, there was an arachnoid cyst in the supracella. And this case was published from AIMS in NEGM. Sensory system is the least possible examination in a child. And it's not that important also, I would say, unless you think of a traumatic spinal cord injury or a traumatic brachial plexus injury. Most of the time, only crude assessment will be possible. If you want to check a pain sensation, use a toothpick. If at all you are using that, try to do it in the last only. Cerebellar examination is actually very important because many of the brain tumors, as you know, in children, they are mostly in the cerebellum, and they may be presenting only with cerebellar symptoms and signs in the initial part. So you can use again a toy to check whether any dysmetria is there, any intentional tremor is there. Even many children, if you are having good rapport, they will cooperate for dysdiagokinesia also. From the gait, you can assess the cerebellar gait is there. From speech, the scanning speech is there. Hypertonia is an important part of cerebellar examination. So it's a skull and spine for any midline tuft is there, any lipoma, meningomyelocele, etc. Meningeal cells you need to examine properly, but as I already mentioned, in younger children, it may not be obvious. The Krennic sign and Brunelleschi sign may not be obvious. So the first picture is something known as a tripod position, where the child is extending the spine by keeping his hand on back. This is to reduce the flexion of the spinal canal so that the meningeal irritation is less. This is what's called retrocolis or opisthotonis in an infant. This may be the only sign of, as I already told, meningitis in an infant. So this is the rough sequence of neurological examination in any child. But as I already told, you need not follow this sequence in every child. From the history itself, you need to focus on, you need to make and understand that which part you need to focus more, and you need to complete that part initially. The key is that you need to first establish a rapport with the parents, because these are young parents, and they are also maybe very much apprehensive of what is going on with the child, what is the doctor going to do with my child. So make a proper communication and make a good rapport. If you are having a good communication with the parent, the child also will be comfortable. The next thing is that touch the child last. Try to observe the child maximum, provide him some toys, but touch him last only, as because once you start touching him, or you're going to take the head circumference first, then the child will burst out into cry and you will lose the opportunity. Ensure that the child is well fed, comfortable, and there is no fixed sequence that one should follow in one child. Everyone can have their own methods and improvisations, case-to-case basis. And what sequence that I follow is that once the child comes with the parent, I first communicate with the parent, take a proper history. While taking history, I'll just look at the child, make some gestures to make him comfortable and make him feel that, okay, we are not that dangerous. Roughly, we can say that there are 4 stages of examination of a young child. Initially, I told first stage is you take a history from the parent, you are observing the child, just communicate through gestures, you are not touching the child at all. The second part, you can just start mingling with the child by providing a toy or a chocolate and asking some questions so that he is comfortable. The third part, you can examine him properly, not only the neurological, the rest also, like hepatosplenomegaly and all, TTR, this all. In the first and second part, the child need to be in the lap of the mother or the father, whoever is there. Third part, you can keep him on the bed. The fourth part, you can ask the parent to undress the child or ask them to walk on the floor to check the motor abilities. So this is a rough sequence that I follow in my OPD. Just observe the child, and that itself can give you many clues, like how is the higher mental function of the child, how is the speech of the child, how is the sensory of the child, and complete cranial examination mostly I follow later, followed by motor examination, followed by making the child walk, and then the other anxiety evoking parts like head circumference, fundus, etc. So this is one rough video of one child who presented with some weakness and lethargy. So I just started talking to him. You need not listen to what I'm talking. It's in Malayalam. But I just started talking to him, and he is giving me answers. I'm offering a toy. I'm moving the toy in all quadrants. Now I know that, okay, he's following my commands, as well as there is no extraocular deficits. In all cases, he's properly looking. There is no up gaze palsy. He's looking up also. I asked him to touch the nose of the tiger, but he was saying that he was doing that, but he was not holding the tiger. If you can see, he is raising the hand, but it's not that proper. It's not a proper abduction that he's doing. Now I asked him to hold the tiger, but he's feared. I gave him a pen, but again he's not that interested. I asked him whether he needs a chocolate. Then he yes. So I gave him a chocolate. I think there's some interference.
Miss Mona, can you mute others?
मेरे को खुद अभी पता चला
Miss Mona,
तुम्हारे मैसेज कर रहे थे तब खुल के देखी फोन.
So by this time, I know that his higher mental function is okay. He's not encephalopathic. He's able to follow my commands. He's not having any extraocular movement palsies. His speech is okay. His memory is okay. I asked him the name and all that. All he was responding properly. I think there's some interference.
Yeah. Miss
So now I offer him a chocolate. You can see the abduction is not that great, but his distal power is okay because he is trying to get the chocolate from me and with a fairly good power. Now I start examining for the tone. For tone, the parts are, one is you need to have a passive stretching. You need to check the flappability of the distal muscles. The distal muscle here is somewhat more flappable than you expect in a 3-year-old child. The tone is also a little bit on the lower side. So now I'm touching him and checking the tone. He's not that apprehensive, but his voice is breaking in. He senses something dangerous. It's just like I'm keeping on talking to him some basic questions only, so that he's not keen on observing what I am doing, just to distract him. Now I'm checking the DTRs. It's not that I don't have a knee hammer. I was using a stethoscope because sometimes children seeing the knee hammer, they may get apprehensive. I was checking the deep tendon reflexes while I'm talking and engaging him, but I'm not getting a reflex. So now what I can understand is the tone is on the lower side. Lower limb, I am not getting reflexes. Upper limb, the reflexes are fairly good. The power is also, the proximal power is also in the upper limb, it's not that great. But cranial nerves and sensorium are okay. Sensory system, as I already told, it's very difficult to assess. But you can ask the history whether he was crying during a cannulation and all. I'm checking the head for any abnormal sutures are there. And the last only, I'm checking the head circumference. Now you can see he is like breaking the voice and he's about to cry. Even though he was engaging in conversation with me, once I started taking the head circumference, he was not that comfortable. Now in the gait, you can see he's not going in a straight line. He is deviating to one side, and there is a wide base gait, and as well as the tone is also not that great. This he has sat. I'm asking him to get up. He is getting up not in a proper manner. He is needing some support to get up. Now he's saying E, there is no facial asymmetry. I can see the tongue. I can see the uvula. There is no deviation. Tongue also, it's okay. There is no deviation. All tongue movements are okay. Now he is comfortable with me and he's following whatever commands I am giving and properly following that. You can see the tone is very much high. He's sitting with so much wide angle. But I'm asking him to get up. He's getting up with some support, not kind of a go over, but there is some support that is needed. So this child was having a proximal lower limb weakness and upper limb proximal weakness. So sensory is spared. Cerebral examination was upper limb, it was normal. He was holding the tiger without any intentional tremor or dysmetria. While walking, he was having the gait was a cerebellar gait. So this was a case of a variant of Guillain-Barré syndrome, which was known as Miller-Fisher syndrome. Cerebellar signs with proximal neuropathy was the case. This is another kid, another girl, 3-year. Unlike the other kid, she's very shy. I was checking the visual acuity. This is what I already told. This is known as the optokinetic drum. This is a crude method to check the acuity of the children in less than 4 years or 5 years. You can use this. It's freely downloadable. You can use in horizontal as well as vertical. And while the child is engaged in looking at one place, you can introduce a step or something from one side to check the field of vision. She is not that worrisome and she's following my commands. I'm asking to show her the mouth, tongue and all, and she's properly following my commands. And all this time I'm not touching her. She's comfortably sitting on her father's lap. She's closing her eyes. 7th nerve, I already told it's okay. She was not interested in a toy. I gave her chocolate and now she's excited. Now you can see the difference between the previous kid and this kid. The previous kid was having the abduction was not that great, but this kid is properly raising the hands to catch hold of the chocolate, of the lollipop. And distal power, I'm checking. Distal power is okay, fairly good. and there is no cerebral intention tremor, there is no dysmetria. She's otherwise a happy kid. Now I start examining her, check for the deep tendon reflexes. Again, she's keenly watching what I'm doing, but I'm just talking to her father and with she, so that she gets distracted. Reflexes are okay, I can find. So the key is that you need to touch the child last. You need to have some toys and chocolates. Without that, it's very difficult. Now I am asking her to kick on my hands. The upper limb power, I know it's fairly good, more than at least 3. Now she's kicking on my hand, and now I know that it's at least 4 because it's against resistance. I'm checking for any abnormal swellings. Are there any abnormal sutures? Skull and spine. Ask her to walk. The gait is fairly okay. I'm checking the pupils now. She's cooperative. She's not worried. The extraocular movements are okay. No dysmetria, no intention tremor. Still, she has not uttered a word. The last part of the examination now, I'm checking the head circumference. She seems okay and not worried. You need to take the head circumference thrice and take the average. You can ask them to sit on the floor and get up to check for any proximal weakness. You can see what's the difference between the previous kid and this kid. She is getting up suddenly compared to the previous kid who had a proximal weakness. She's following all my comments properly. So, as I mentioned, there is no fixed sequence for a particular kid. It is that just that the parent and the child should be comfortable, and you also need to be comfortable. You need not check each and everything in every child. Based on the history, you need to focus the examination, which part to be focused more. So the take-home messages are proper rapport with the parent should be made initially. Maximum information to be obtained by observation only. Touch the kid last only, and try to offer toys, chocolates without any risk of aspiration. That should be important. And perform a focused approach based on the history. Thank you.
Thanks a lot, Dr. Vaishak. It was a very detailed presentation and a very good one. I'm sure all the listeners would appreciate both of your presentations as a very apart from the details, the efforts you have taken. Sincere gratitude for the same. Thanks a lot once again. I think one of the key points which we have learned is probably everybody would appreciate that we need to have appropriate knowledge, we need to be patient, we need to be innovative in the approach, and at the same time, very respectful to the parent and highly respectful to the child's overtures. Thanks a lot to all of you who have joined. Dr. Amresh and Dr. Naveen, would you want to comment and take some time? We don't have much of time for questions because we have to stop at 8 o'clock. But Amresh and Naveen, you can go ahead with some comments. So.
Yeah, thank you, Dr. Vishak and Dr. Sneha. I think you demonstrated very well all the signs, and it's very important to establish a rapport between the child and the parents. I think that is one of the basic things. The whole aim was that our residents should learn and try to develop this examination skills. Thank you. I think we don't have much of the questions today. I think Dr. Amresh is there.
Yeah, Amresh is our guest teacher, associate professor from Bangalore Medical College, and his residents have also joined. Amresh, you can give your comments on. You're muted. Amresh, you're muted. You need to unmute yourself. Amresh, you're muted. Dr. Amresh, you're muted.
I think you just put a message.
Yeah, I don't know. Yeah.
Thank you, Suhas, and the Pediatric Neurosurgery Association for actively involving us in this fourth webinar. It was very informative and very lucid talk by Dr. Sneha about the neurological examination of the neonates. We usually never touch them before surgery. Directly go and do procedures by seeing the scan. So it was a very good opportunity for our students to learn. Yeah, they got very good opportunity to learn from this forum. It was really very informative.
Thank you, sir.
And a very good presentation, Dr. Vaishak also. Thank you so much. I think our students should ask some questions if they have any.
I think to all the residents, these are sessions meant for you. It's a small attempt by the society to inculcate some good pediatric neurosurgical knowledge and habits and get a comprehensive development of your career. I'm not sure we have much time for questions.
Yeah, with the questions also in the chat box.
Yeah, they had, but it was just comments only. One, they appreciated both the speakers very well. Both had taken, I mean, that they have clearly very everybody has clearly mentioned what nice presentations. I don't see much of. Yeah, one question is how Vaishak, I understand how to examine fundus in a very young child. You want to comment on it, Vaishak?
Yeah, so I have given a reply already. So in young children, it's difficult without dilatation and sedation. It's very difficult. And definitely what we do practically is we give mild sedation and dilatation for the fundus examination.
Yeah.
Yes, even in a neonatal age, we have to dilate and see. And usually our concern will be more of ROPs, that is retinopathy of prematurity. Very rarely if there is any signs associated with syndromes. So we don't routinely do a fundus examination for a neurological evaluation.
I don't see any more questions here. That's one mentioning red flag sign.
Get to know neurological assessment.
So red flag sign, it depends on what case you're suspecting. So what I would say is a young child who is cranky and all, it's normal. But a child who is very much lethargic, he's not at all responding to you and he's just calm and quiet, that should be a red flag, that contrary to the popular belief. So a calm child, even if you are a stranger and he's seeing you and he's just having no reaction, he's just calm and quiet, you should think that, okay, the child may be encephalopathic. That's a red flag sign. And depending on different case scenarios, like in headache, we say some red flag signs are there, like a new onset squint in a headache is a red flag sign. An early morning headache is a red flag sign. A headache that makes you wake up from the sleep is a red flag sign. New onset deficit in a case of headache is a red flag sign. So it depends on what case you're dealing with.
Yeah. Thank you. Any other questions? I think maybe we'll have to close the session here. I think Naveen, Dr. Amresh, shall we go ahead with closing because it's already.
Yeah. Thank you so much.
Yeah. Go ahead, Amresh. Can talk. Amresh, go ahead.
I think we should have more questions. Then we can close the session here. Huh?
Yeah. Thank you.
Thank you, Vaishak. Thank you,
Suhas.
Yeah. So thanks a lot, Dr. Vaishak and Dr. Sneha. You had you have put great efforts, and since I get for the same, again, I am repeating it again because I thought it was a great presentation from both of you. Thank you, Amresh.
Thank you.
For joining the session, and I think at least your residents might get inspired to join us regularly for the training, and Naveen, of course, and I think to the residents, this is a regular session every month, the last Sunday, 7 to 8 p.m. We have kept it very standard and regular with the same link, so you can always join us with the links from the previous presentations. Additionally, You should remember, but if you fill up the Google form, you'll get the message for all the talks from here onward. The next session is on biomechanics of pediatric spine, which will be on the last Sunday of August, conducted by SGPGI Lucknow. Thanks a lot once again to all of you who have joined us. Thanks a lot to my faculty, Dr. Resh and Dr. Naveen. Thanks a lot.
Thank you.
Good night.
Good night.
Good night to everybody.
Trainees is really glad to have all these brilliant people together in the session today. So thank you so much for extending us the opportunity to host the session. I hope you all had a seamless experience. So with your due permission, I'm closing the session today and looking forward to hosting you again. Bye and good night to all of you.
Thanks a lot. Good night.